Thank you very much, and sorry for the delay. Good afternoon, morning. So I know the most intriguing word that you see on this title is psychedelics, more than likely. I assure you I will get there eventually. But before we can get to the psychedelic part of this presentation, we are going to have to talk a little bit about fibrinolysis. I'm aware that most of you have some degree of medical training and are familiar with the clotting processes in the blood, but I will all the same elaborate just a few basic review steps in this review. I will explore some speculative literature that may connect psychedelics to antidepressant effects as a result of modulation of the fibrinolytic system. Newer models of treatment-resistant depression implicate the roles of inflammation, especially neuroinflammation, chronic stress, and disrupted synaptic plasticity. Fibrinolysis, which is downregulated by inflammation, has not previously been studied as extensively as those factors that I mentioned previously. Of note, certain disease states, such as coronary artery disease, have been demonstrated to be an independent risk factor for depression and vice versa, prompting the inevitable question why that is. Also, inflammatory states such as COPD are prothrombotic, which is to say, anti-fibrinolytic. There is a chemical called brain-derived neurotrophic factor. It is essentially a protein that promotes brain growth, prevents damage, promotes repair, generally protects against programmed cell death. That factor is increased by chemicals such as tissue plasminogen activator, which you may know we give in acute stroke patients to break up clots. However, TPA inhibitors seem to decrease that factor, suggesting that there may be a link between those disease states and the frequently comorbid depressive state. I wish to emphasize that in this talk I am reviewing speculative literature that may explain how psychedelic agents such as psilocybin, mescaline, LSD may exert antidepressant effects which have been observed for decades but not so intensively studied until very recent times, owing to the obvious stigma against them. And they may do so by restoring a balance of the fibrinolytic system. In short, pro-clotting states seem to happen at the same time as depression, seem to be a factor in that, and I will explore ways in which that may be the case. For fun, I'll also mention a few of the studies that were done back in the 50s, although older research methods are, well, older. So just in the real quick, I put this for those who may be a little further away from medical school or for having studied this. Here we have tissue plasminogen activator, which I just mentioned. Normally it's released from the walls of a blood vessel. This whole thing's just a blood vessel. And this is a blood clot. This is what's called a zymogen, an enzyme that is activated by another chemical. Plasminogen gets converted into plasmin, and plasmin helps break up clots, resulting in the FDPs. These are basically just breakdown of the clot, fibrin degradation products. By contrast, there are inhibitors that can get in the way of plasmin. I recognize that at first glance, this slide might seem a little overwhelming. So I'm going to walk you through step by step. First off, TPA and its cousin UPA, as we showed on the slide before, can convert plasminogen into plasmin. And plasmin works to break down clots. What some people don't know is that plasmin also converts brain-derived neurotrophic factor into an active form, whereas previously it's stored in this pro-BDNF, this inactive form. So when there's basically high plasmin activity, clot breaking, there also tends to be a lot of conversion of brain-derived neurotrophic factor into its mature form. Conversely, inhibitors of things like tissue plasminogen activator and its cousin UPA, these are often elevated in depression. They go against the conversion of plasminogen into plasmin, which means that not as much mature brain-derived neurotrophic factor is being released. And we'll talk about some of the consequences of that in a moment. Additionally, fibrin that just happens to be around for any reason, especially prothrombotic states like the aforementioned coronary artery disease or chronic obstructive pulmonary disease, many others, will tend to compete with plasmin. Plasmin can only really do one thing at a time. So you have some of it converting pro-BDNF into mature BDNF. You have some of it working on converting fibrin into its active state. If there's an awful lot of fibrin around, then it stands to reason that you're not going to have as much conversion of mature brain-derived neurotrophic factor. There is a lot of thought that that may result in depressive pathophysiology and other mental health conditions. Finally, on this slide, I'm just reinforcing that inhibiting fibrinolysis, which is to say increasing the amount of fibrin, means that you're not going to get as much of this conversion from pro-BDNF into its mature form. In depressive states then, especially in situations where you have prothrombotic states, you actually have a double effect going on here. You have higher levels of these cytokines, such as neuroserpin, PAI1. These things tend to be elevated in depressive states. They block the conversion of plasminogen into plasmin, stopping mature BDNF in that way. Then you also have high amounts of fibrin kicking around, and that blocks plasmin directly. So it's a bit of a double dagger. In passing, I'll mention that when you have decreased amounts of UPA because of inhibition of the cytokines that I just mentioned, it will tend to upregulate the amount of the receptor for UPA. As a consequence, that receptor finds itself being metabolized. And it has been revealed in some studies that the product of the cleavage of this upregulated receptor might actually be a potential marker for depression state, depression severity. The implication is that, though not easy to statistically prove just yet, we are always on the lookout for potential markers that may assist us objectively in gauging how severe a depressive state is other than what we get clinically. So actually, this diagram is really kind of a continuation of the previous one. We have plasminogen activator activity decreasing in this seesaw. And these are the same neurotrophic factors, the cytokines that I mentioned before. On the previous slide. The more plasmin activity we have, the more this pro form of brain-derived neurotrophic factor is increased into mature brain-derived neurotrophic factor. Anything that gets in the way of plasminogen activator activity will influence this balance, potentially resulting in all kinds of mayhem. Not limited to, but including decreased BDNF, impaired astrocyte reuptake of glutamate, that can result in overstimulation of glia and cell death, excess NMDA receptor stimulation, same story, microglial activation, disrupted plasticity. It may be intuitive, but I will say all the same that synaptic plasticity and mental health do tend to run together. The more plasticity, the more mentally healthy someone tends to be, and there's a fair amount of literature about the correlation about lack of plasticity and depressive phenomena. Disrupted neurogenesis, again, if you're reducing the neurotrophic factor, you're also disrupting the neurogenesis. And once again, the transient fibrin deposition. And we just talked about here in the previous slide what happens when you have excess fibrin. It ends up starting a vicious circle, potentially. All of these factors in turn result in phenomena such as hippocampal atrophy, disrupted brain circuitry, and major depressive phenomena. So again, stress increases inflammatory cytokines. Things like TNF-alpha, there's a chemical called PAI-1 that basically just inhibits TPA and UPA. PAI-1 in turn inhibits the formation of the brain-derived neurotrophic factor in its mature form, causing all of these consequences I've just discussed. Ultimately, hippocampal atrophy and disrupted circuits may contribute to depressive pathophysiology. Microglial activation, which I just mentioned. Under stress, it seems that astrocyte reuptake of glutamate is impaired. That can result in increased NMDA receptor stimulation, neuroinflammation, and depression. Again, reiterating what I just mentioned a few moments ago. Disrupted plasticity is another consequence. Whereas TPA normally promotes plasticity by basically helping clean up some of the gook in between neurons, utilizing enzymes called metalloproteases. When that chemical TPA is interfered with, you have more matrix, more gook getting in the way, and decreased plasticity. In depression, PAI-1 is indicated in doing precisely that, inhibiting TPA. It is of note that the inactive or premature form of brain-derived neurotrophic factor itself tends to induce dendritic retraction. So not only when we interfere with the pro-BDNF to mature BDNF conversion, are we not getting the effects of the mature chemical? We're actually causing some problems just from pro-BDNF's presence, such as dendritic retraction and also programmed cell death. By contrast, as I've mentioned, mature BDNF does just the opposite. So it's a delicate balance. And I'm suggesting that in high thrombotic states, based upon literature that has been reviewed, you have higher amounts of pro-BDNF and lower amounts of mature BDNF, just like we see in this seesaw over here. And again, as before, fibrin tends to compete with pro-BDNF for plasmin, resulting in creation of less of the mature factor. This can get complicated, so I hope you won't mind repeating myself a few times. Now, I know you're wondering about the psychedelic portion of my talk, and I assure you I'm about to get there. Animal model studies have demonstrated that TPA and BDNF have been increased in the hippocampus of rats and other animal models treated with sertraline. Psilocybin, the psychedelic, mindfulness meditation, seem to have similar effects. They reduce default mode network activity, which seems to reduce rumination or negative self-referencing. Interestingly, that has been demonstrated in certain papers on post-traumatic stress disorder to be a durable effect after psychedelic treatment, but more on that in a moment. In any case, it has been suggested that psychedelics reduce stress and actually increase the breakdown of clots, increase fibrinolysis. Whereas, remember, we're operating on the premise that impaired fibrinolysis causes depressive symptoms and mayhem through a bunch of different reasons. Psilocybin and LSD are 5-HT2A agonists. For your residents, just be aware that does get tested on the prite, so watch out for that one. These are associated with platelet aggregation and thrombus formation. So actually, the 5-HT2A system here is prothrombotic, anti-fibrinolytic. When you downregulate that receptor, make less of it, you are achieving, therefore, the opposite effect. It is thought by some that an antidepressant effect mediated by LSD, psilocybin, and others might be because by providing exposure to the agonism, you downregulate the 5-HT2A receptors. It has also been convincingly studied in some papers that 5-HT2A is upregulated in depressed and suicidal patients post-mortem. An intriguing finding. I've also included, just for interest, that there have been some LSD studies in the animal model, in this case rabbits, that showed downregulation of 5-HT2A within a couple of days, suggesting that it might be possible to develop a psychedelic drug that had a more rapid effect. (5-HT2A) is also upregulated in mice under chronic stress, and there are various ways in which that's simulated in the animal model studies. These chemicals, PAI1 and TNF-alpha, which are old friends of ours by now, they are prothrombotic, anti-fibrinolytic, and are increased in stressed mice with depressive symptoms. Mentioning in passing, ketamine also is influential in this system. Not wanting to get into IL-6, I'll mention that PAI-1, TNF-alpha can also be suppressed by ketamine therapies. This isn't a ketamine discussion, but that is another potential link between some of the research that I'm presenting today. Of course, as we know, there's a lot of study on ketamine as an antidepressant in recent times. I've also mentioned there's this RDOI. Most people probably have not heard of this psychedelic agent. It's another 5-HT2A agonist that is psychedelic, but not a stimulant, despite the fact that it is an amphetamine. It seems to be a bit more specific for that 5-HT2A receptor than maybe LSD or psilocybin is. And so the labs have been playing around with that to see if they can get results. And so far, they're suggesting that that might block TNF-alpha signaling, which again is pro-inflammatory, prothrombotic, anti-fibrinolytic. And that's our DOI. Just for giggles, I threw that slide in. So psilocybin may act through the limbic system. There is thought that it may attenuate amygdala hyperactivity. Remember that negative self-referencing I mentioned? Ruminative pathology, I'm the worst, I can't be better. The infinite loop that we sometimes see in certain depressive patients can be as a result of hyperactivity in that region of the brainstem. There is thought that psychedelic agents may be unusually good at disrupting that circuit, and potentially in a durable way. There have also been studies that have suggested that this influence may also assist in extinguishing fear conditioning, which, as we know, is a very major player in the pathophysiology of post-traumatic stress disorder. I will also mention that it has been seen that there have been upregulated 5-HT2A receptors in obesity, especially in adipocytes that are hypertrophic. You have this upregulated 5-HT2A and PAI-1, and so there's thought that there might actually ultimately be a potential weight loss benefit to modulating this 5-HT2A mediated fibrinolytic pathway through agents such as psilocybin, LSD, RDOI, what have you. Now, going back in history for a little bit, you know, LSD and psilocybin used to be perfectly illegal. There are a few people in the room that can remember those days. They went illegal in 1967, but during the Beat era, Ken Kesey, Jack Kerouac, what have you, there were a lot of people playing around with LSD in a, well, somewhat less scientific manner. There were some people doing some research on it, however. Numerous trials featured the amplification of psychotherapy, which of course was also a process in its own evolution, by adding LSD as a part of the therapy. Some studies that I reviewed even talked about having a music therapist, an art therapist, a spiritual guide, a psychotherapist, in conjunction with LSD therapy. I know you'll be shocked to know that many results were quite positive. People seem to have had a pretty good time on the main. as a result of their experimentation. It appeared to researchers that LSD, psilocybin and the such, might have beneficial effects. But there's a little bit of a problem with some of the older studies. Not the least of which being, they're older. The paradigms and language of psychiatric illness have shifted quite a bit since days of old. If you look in your DSM-1 or 2, you might find entities like hysteria, homosexuality, neuroses, things which are, well, we don't really necessarily call those diagnostic entities anymore, but even if we did, they'd be open to broad interpretation. What were they talking about? It's hard to say for sure. Even they weren't really all that sure. I'll also point out that not all depression is depression. There are some that are neurovegetative, there are some that are hypersomnic, atypical. We use melancholia. Simply reporting that you had depressed patients doesn't really give us all that much of a diagnostic acumen. And with another 50, 60, 70 years, we've refined our categorizations, but we're still arguing over it. Things wax and wane. So when you're trying to look in the old studies as to whether psychedelic drugs might have had antidepressant effects, you run into some of these stumbling blocks. You aren't sure exactly what the states of the patients that they were treating were. You're not really sure how to categorize. But there's also the fact that their statistical analyses, well, to be candid, just weren't very good in most cases. Statistics has evolved over the decades as well. Now we have our chi-squares and p-values. Now we have a bit more of a standardization of measurement effects. But back then, the research was a lot more primitive and very difficult to reproduce, except in a very kind of allegorical way. There were lots of anecdotal evidence, assessments that just weren't completed or done thoroughly, statistics that, let's just be honest, were naive. Poor follow-up, poor sample sizes, lack of controls, you name it. I even read a few studies where they thought that they were getting such a great benefit from psychedelic treatment, LSD, what have you, that they thought it would be unethical to not give it to the control group too. They thought that they would really be doing the depressed patients a disservice by not allowing them to join in. In terms of scientific credibility, well, it wasn't always the first concern of the researchers in some of the studies that I reviewed. I'll also point out, just in passing, I didn't really see too many reports of adverse effects, but of course there were always a few of those. The link between neuroinflammation and mental illness is well established. What isn't necessarily quite so established is how or why. It seems reasonable to suggest that it would be a multifactorial phenomena. The purpose of my talk today is to explore one particular avenue in which that might have been influenced or might be influenced. Again, we know coronary artery disease and depression are independent risk factors for each other. Further, there might be a way that actually targets some of those phenomena that has actually been around for decades, but never really treated or researched appropriately in a way that we can actually make strong, repeated evidence and inferences about. In short, it might be worth having another look at some of these substances or variants of them that might not have the obvious problems. Of course, the stigma against LSD and what have you is there for a certain amount of reason. There are problems and barriers that come with using psychedelic agents as treatments. That does not mean, however, that they should be summarily ignored. Dysregulating the fibrinolytic system might be one explanation of the link between neuroinflammation and mental illness. That dysregulation may help explain the links, as I've mentioned, between pro-inflammatory, pro-thrombotic states and depression. Activation of plasminogen by enzymes such as CPA, UPA result in the formation of brain-derived neurotrophic factor in a mature form. That in turn improves plasticity, decreases cell death, decreases atrophy in the hippocampus. Fibrin does the exact opposite. Psychedelic drugs, especially those that influence 5-HT2A, may downregulate that receptor. In turn, that has a prothrombotic antifibrinolytic effect. It reduces the amount of fibrin that's around to interfere and muck things up. That downregulation may explain the previously noted studies, though they were somewhat anecdotal, that suggested that psychedelic drugs may actually be very effective antidepressants in a durable way, especially in patients that have comorbid antifibrinolytic conditions. If we know nothing else, we do know that the SSRIs don't work on everybody. And so we're left to explore, well, how else is depression maybe being caused? This presentation is simply a speculative review of other possibilities. Psychedelic drugs do have their drawbacks, but they may deserve further research, updated with today's statistical standards, and maybe this time we'll actually have a control group, huh? I thank you very much for your attention. I realize that this is complicated, so I've decided to leave a fair amount of time for questions. It's a real privilege. Thank you. No?
Do I have it on? Oh, there it goes. Thank you, Dr. Forrest, for that great presentation. Do we have any questions? Yes.
Dr. Roy.
So is there evidence that LSD or psilocybin, either one or both, have anti-inflammatory effects or inhibit cytokine production or anything along the neuroinflammation path?
I do believe that there are some papers that are suggestive of that are source I haven't read all of them in the same detail. Most of the data information I have presented in this talk comes from a speculative paper in the Journal of Medical Hypotheses.
Right.
However, they're doing a lot of stuff in the animal models. What it seems to be from my review of the literature is that they're starting to try to work that into the clinical realm now.
So separately,
yes.
like what percentage of depressed patients are ruminators? And that
Now that is a good question.
I mean, I don't really know. That seems
I wouldn't know where to look to find that information, but I'm glad to let Dr. Goodkin have a shot if he wants one.
Well, actually, I'm interested in another question I'd like to pose to you, Dr. Forrest.
Yes.
You talked about a lot of interacting networks and concluded it's quite complex, which I agree. Do you see there's a reason to focus specifically on the fibrinolytic system with what we know now, as opposed to, for example, inhibitors of pro-inflammatory cytokines like TNF-alpha with etanercept and petoxyphylline?
Yes, so one of the things that I thought was particularly interesting about this slide in particular is that, here we have the things that come from inflammation from TNF-alpha, but we also have the fact that fibrin actually does directly have an influence upon mature brain-derived neurotrophic factor. That is suggestive that pro-fibrin states, or anything that results in clotting, may have a role. So it would be another way to consider the same
right, but
problem.
The pro-inflammatory cytokines are also directly related to BDNF. So.
Oh yes, absolutely. And this slide certainly goes into that. I'm just pointing out there might be things that ultimately result in fibrin that aren't necessarily directly neuroinflammatory. Now, if I had to hedge my bets, I guess the neuroinflammatory cytokines are frequently the bigger issue at play, and based upon the pattern of what I'm seeing in the research, like who is studying what, that's what they're going after. That said, I don't think we should forget the fibrinolytic system, because I've always been very intrigued by the way certain prothrombotic conditions tend to cause depression, not just because of necessarily lack of functionality. But when you hear that these things are actually independent risk factors for each other, that depression might result in higher thrombotic states from sickness behavior or what have you, I think it's an intriguing thing to study and consider.
I wanted to follow up from my two contrasting questions, and the reason for them is that it's possible that these compounds, ketamine and LSD, etc., have anti-inflammatory effects or anti-neuroinflammatory effects. But I just tend to think that since they work so rapidly that we're actually disrupting something rapidly, and anti-inflammatory effect is not going to have, I don't believe, a rapid behavioral effect. It's going to be a very slow improvement. So I tend to think these drugs are more like using a ball bat to disrupt something like rumination. You disrupt that repetitive thinking or negative pattern by completely shocking the brain in some way, either through a hallucination or disassociation. And that disrupts that behavior, and that's the initial improvement that you get in behavior. But the anti-inflammatory effects, I just have a hard time believing that those are going to have a more immediate effect.
Of course, as to that, I have no particular disagreement nor necessarily agreement. I would say that this is an intriguing area of potential further study. How neuroinflammation actually gets disrupted, it seems to me that, well, we have a toolbox for a reason. Not everything should be treated the same way. And that the more tools, the more modalities that we have, the better off we are. We do find ourselves in cases of treatment-resistant depression. And hey, if nothing else is working, I'm all for, especially if there is at least some scientific base, that there might be a distortion in something that hasn't been looked at as exhaustively, that we shine a light on it and see what we can discover.
Hi there. Thank you for the presentation. I'm Andrew Block. I'm a psychologist at the VA. You had mentioned the low quality of some of the research that has been done on psychedelics and depression. I have just this past week, actually, my wife gave me this new book by Michael Pollan on psychedelic research on depression, which is fascinating to me, and it does seem as though there are some new studies out there, though with extremely small n's, which are showing some promise with more evolved, more current research that shows there's some real promise in the field. I wanted to know if you had any, if you looked at that at all and had any thoughts about the future of where this might lead.
Nope.
Okay. All right, that's fine.
Haven't seen that.
Okay.
Haven't seen it yet.
All right, no problem. Thanks.
Hey, Jeff. Thanks for the presentation. I have a question. While you were looking through the literature, did you come across anything mentioning about patients that have a inherited defect of pro-inflammatory response with the depression, with the psychedelics, anything like a pre-genetic disposition on the patient?
I was not able to find anything on that just yet, but I think it would be an awful intriguing study for someone to take up.
All right, thanks.
Thank you for the presentation. I enjoyed that, and I was thinking about also some of the more recent research on using psychedelics to treat addiction, MDMA-assisted psychotherapy to treat trauma, psilocybin-assisted treatment for anxiety related to cancer treatment, and so it makes me wonder if there is a common pathway in the fibrinolytic system there, and if you had given any thought to that.
Yeah, actually, as it turns out, there is a rather intriguing study about MDMA in mice and what you exactly were discussing. However, I decided that would get me too far into the bush. This is a detailed there's a lot of fine and nuances in this, and I didn't wish to get lost in one presentation. But yes, my sense of it is that there are mental health conditions, everything from addiction to PTSD, depression. It's not just about depression. That psychedelic agents are getting a lot of attention in the treatment of a variety of mental health conditions. My sense of it is that ultimately it does come down to things like neuroinflammation, fibrinolysis, disruption, and all that sort of thing. However, we're studying it in more detail in the animal model, and I'll be excited to see the clinical trials with humans, which will elucidate as to whether we can actually, with some degree of statistical significance, prove the things that were consistently, suggested back in the 50s and 60s. They may have actually had something that really worked well, but it's just real impossible to prove. They may have been basically treating people successfully almost by accident. getting a clarification as to how that happened and why, I think would be excellent.
Are there any other questions? I actually have a question. I was wondering, so you talked a lot about the positive benefits psychedelics with depression, but I wonder about conditions with psychosis or depression that has psychosis. Is there a positive benefit, or are there any risks?
Well, I mean, anytime you have somebody whose reality testing is at baseline impaired, I just talking without
Right.
having the clinical experience would speculate, well, gee, how are you going to gauge the difference in the psychotic symptoms if you've now introduced something that might cause someone to hallucinate on top of that? So that would be a very risky can of worms to me. Certainly only in, there's a long line of things I would probably want to be doing in a floridly psychotic patient ECT. There's clozapine. There's a lot of other things that you might be wanting to consider if you really needed a treatment that badly. Psychedelics probably have limited, to me, use in that situation because of the distortion and our possible hamstringing of ability to track the progression or regression.
I just wonder where you
symptoms.
said that there were some adverse effects. So if people who have very severe depression, if there's any risk of them developing a depression with psychosis if they had treatment.
I mean, bad acid trips have been, that's been documented for decades. And I know that I think that this was kind of an urban legend, but I used to hear people talk about it because they like to say it, that if you'd had such and such amount of LSD that you couldn't get a medical license because all of a sudden you can get flashbacks and what have you. I believe that's actually an urban legend, but all the same, I mean, there are risks to playing around with these kinds of agents. And so it's not done lightly.
Thank you. Any other questions? Well, thank you very much for the great presentation.
Thank you very much. It's a real privilege.